Okay, so the characteristic of osteosarcoma, so if we want to diagnose osteosarcoma, no, under the microscope, we first look the presence of osteoid, no? We look for osteoid kasi kung walang osteoid, walang osteosarcoma. Okay? Because when you see osteoid, so as you can see here, these are eosinophilic, homogeneous, glassy appearing lace-like material. So they are the product of the bone. So kaya characteristic talaga yan ng osteo. Kaya naghahanap tayo ng osteoid. Ang tawag niya ay osteoid, bone-forming material within the tumor. Okay? So we don't look for these cells. We don't look for these cells kasi parehas yan ng mga cartilage also. Ang tinitingnan namin ay we look always for the osteoid. Okay? So when there is a mention of osteoid in your board exam, wala nang iba yan. It's a form of osteosarcoma. Okay? So can you make it lower? Okay, genetics you mentioned. Okay, very good. Sige pa, lower. Okay, very good. You have your references. Okay? So thank you, Dr. Alagase.
Thank you, Doc.
Congratulations. Next, we'll have a case of Glucagonoma under Dr. Cawile.
Glucagonoma. So these are neuroendocrine tumors originating from multipotential stem cells of endodermal origin. So they arise from the alpha cells of the islets of the pancreas. So most glucagonomas are solitary. However, less than 10% of them have been associated with multiple endocrineoplasia type 1 or MEN1 syndrome. For the epidemiology, glucagonomas are sporadic and are rare. So the annual occurrence is at 1 in 10 million to 10 is into 10 million. So they are typically large, which is greater than 3 cm, and located mainly in the tail or the body of the pancreas due to the high prevalence of alpha cells in this area. So over 50% are metastatic at the time of diagnosis. The incidence of glucagonoma in males and females is similar, and most patients with glucagonoma would present in the 5th to 6th decade of life. For the clinical presentation, uncontrolled glucagon secretion by the tumor causes a distinctive syndrome of glucose intolerance, anemia, weight loss, depression, venous thromboembolism, and skin rash. So diabetes mellitus is present in nearly 80% of the patients. It is mostly mild as beta cell function of the pancreas is preserved and hence the production of insulin-mitigating ketoacidosis. There is also chronic diarrhea, which is seen in about 30% of the patients with glucagonoma syndrome. Weight loss is also the most common presenting feature seen in 80% of cases. This is due to increased lipolysis and gluconeogenesis from fats. There can also be neuropsychiatric manifestations such as depression, dementia, and psychosis. So there is also necrolytic migratory erythema. So this is a dermatosis that is associated with glucagonoma syndrome. So it is present in up to 90% of the patients. So it is widespread with main areas of involvement being perioral, perigenital regions, and the extremities. This often starts out as pruritic and painful erythematic papules or plaques, which would gradually enlarge and coalesce to form bullous lesions. Mucosal involvement presents in the form of angular cheilitis, glossitis, stomatitis, and blepharitis. Patients may also have hair loss and nail dystrophy. So this is caused by decreased amino acids and poor nutrition. The diagnosis of glucagonoma is made on the basis of a combination of history, PE, laboratory diagnosis. So there is elevated glucagon levels at usually more than 500 picograms per ml. There is also elevated glucose. CBC will reveal normocytic anemia. And for the comprehensive metabolic panel, chronic diarrhea would cause electrolyte abnormalities, and hyperparathyroidism in MEN1 would present with increased levels of calcium. So other laboratories which may be obtained which are of importance to glucagonoma diagnosis include serum parathyroid hormone, gastrin, insulin, pancreatic polypeptide, serotonin, VIP, prolactin, and adrenocorticotropic hormone levels. On skin biopsy, for the gross pathology, they are usually solitary, well-circumscribed large solid tumors with an average size of 5 to 10 cm. For its microscopic features, histologic features of glucagonomas are similar to and indistinguishable from other pancreatic neuroendocrine tumors. So they are almost always well differentiated and composed of uniform cells arranged in densely packed anastomosing trabeculae separated by scant fibrovascular stroma. For the initial management, first we must control the diabetes. We can also give nutritional support which may require total parenteral nutrition. Somatostatin analogs such as octreotide may also be given. So this is to inhibit glucagon secretion, to improve diabetes, diarrhea, and neurologic symptoms. DVT prophylaxis such as heparin may also be given. For the advanced management, pancreatic resection should be done if it is localized to the pancreas. Hepatic resection if there is limited liver involvement. Hepatic artery embolization for more extensive metastasis. And radiofrequency ablation of small liver lesions in chemotherapy. And molecular targeted agents for advanced disease may also be given. For the prognosis, so there is a 5-year survival rate after surgical resection, which is 70% for non-metastatic tumors. However, the overall cure rate remained low at 20%. So that is my whole presentation for
Getalado, and I will be discussing about meningioma. So this is my poster. So meningioma is predominantly a benign tumors in adults, and they arise from meningothelial cells of the arachnoid in the brain. They are usually attached to the dura, and the most common cytogenic abnormality is the loss of chromosome 22, especially the long arm 22q. So for the morphology, the meningioma is a rubbery, rounded, or bosselated dural mass. So they may also grow in plaque, in which the tumor spreads in a sheet-like fashion along the surface of the dura. The lesions range from firm to finely grapey or sand-like. So the rubbery, rounded, or bosselated dural mass can be seen in the first photo. So among the common patterns of meningioma is the meningothelial, with clusters of epithelioid cells with fuzzy or indissoluble cell membranes. Another is the fibroblastic, with intersecting fascicles of spindled cells and abundant collagen deposition. Another is transitional, which is a mix between meningothelial and the fibroblastic features. Psammomatous, on the other hand, they have predominance of psammoma bodies, the latter representing concentric rings of calcification deposited over pre-existing whorls as seen in the second photo. Another is atypical meningiomas, considered WHO grade 3, about 1/4 of meningiomas with higher recurrence rates and more aggressive local growth. Next is the anaplastic or malignant meningioma, that WHO grade 3. They are considered highly aggressive, with highly aggressive malignancy that often resembles a carcinoma or sarcoma. Another pattern is the papillary rhabdoid meningiomas, which are rare, considered WHO grade 3 variants, and also with high recurrence and mortality rates. So for the clinical features, they are usually slow-growing tumors. So either with vague non-localizing symptoms or with focal findings referable to compression of the underlying part of the brain. So usually the most common symptoms are the headache, seizures, or weakness of body parts depending on the affected part of the brain. So common sites of involvement are the parasagittal aspect of the brain, convexity, dura over the lateral convexity, wing of the sphenoid, olfactory groove, the sella turcica, and foramen magnum. They are usually uncommon in children, with a moderate female predominance and a rate of phase 2. The lesions are usually solitary. So for the whole poster, this is the whole infographics.
So medullary carcinoma of the breast, this is a special histologic type of invasive breast carcinoma. In general, carcinoma of the breast can be in situ or can be invasive. And for the invasive, there is also a no special type, which is the typical ductal carcinoma, and this one, special histologic type, one of the special histologic types of invasive breast carcinoma. Meron pang iba. So for the epidemiology, this is often present earlier in life, the median age of 53, around 45 to 62 years old. And this is rare, which comprises only less than 5% of all the invasive breast carcinoma. For the risk factors, these risk factors is in general with the breast cancer. So first is female gender, of course, mostly 99%, and the 1% sa male. Meron ding breast CA sa male. Then increasing age and genetic inheritance. So mostly pag may mga first degree relative na may breast cancer, higher risk also of acquiring breast CA. And then exposure to estrogen. The role here of estrogen is that it stimulates the hormone receptor positive breast cancer to grow, or they help in proliferation of the breast cancer cells. So first, ito, nulliparity, hindi pa naging pregnant. Kasi continuous yung ovulatory period niya. So continuous yung pag-express niya ng estrogen. Kasi di ba pag pregnant, nagiging anovulatory tayo. And also in lactation, we all know that lactation also can suppress ovulation. Kasi di ba nga, natural fertility method also is the pag magbe-breastfeed. So anovulatory tayo that time, so walang estrogen. So pag hindi ka makapag-breastfeed, continuous din yung expression mo ng estrogen. And this one, this symbolizes mga menopausal hormonal therapy. So menopausal hormonal therapy, it contains estrogen also. So it's another exposure to estrogen. And then environmental and lifestyle factors. Here, mga environmental toxins, examples are pesticides and organophosphates. So they say na they have mga estrogenic effects. And also high alcohol consumption and postmenopausal obesity and physical inactivity, mga sedentary lifestyle. Okay, so let's now move on with the histologic features. So these 4 histologic features should be present all in order to diagnose medullary carcinoma. So first, solid sheet of large cells of pleomorphic nuclei. Second is there are frequent mitotic figures. And third is moderate to marked lymphoplasmacytic infiltrate surrounding and within the tumor. And fourth is the pushing or non-infiltrative border. So this picture is taken from Robinson Cattrall. So we have dito mga lymphocytic infiltrates, and then we have a pushing border. This one, pushing border. They do not infiltrate, or there is no invasion in the surrounding stroma. And for the other features, these are mostly associated with BRCA1 mutation and the TNBC or triple negative breast cancers. Because in breast cancer, we have 3 major groups. Yung luminal or ER positive pero HER2 negative. We also have HER2 positive, and for the third, it is the triple negative. Triple kasi negative siya sa ER, HR, HER2 at saka sa PR. And then they have better prognosis than other poorly differentiated carcinomas because they have large numbers of infiltrating T lymphocytes. So the body must be fighting this tumor with all these lymphocytes, kaya siguro mas better yung prognosis niya compared to others. And they are softer than other carcinomas due to minimal desmoplasia, and then often form well-circumscribed mass. So actually, the medullary is derived from the Latin term medulla, which means marrow. Diba yung bone marrow is soft, so kaya soft, medullary is soft. Yun. So treatment is surgery plus targeted therapy based on the ER/PR and HER2 status. So these pictures, I got them from Pathology Outline. So this shows the gross image of the invasive breast carcinoma with medullary pattern. So there's a white mass with circumscribed pushing border. And this one, abundant lymphocytic infiltrates. Ito naman, may mga mitotic figures, numerous mitotic figures, and here, mitotic figures pa na yung nuclei niya at saka prominent yung nucleoli. Yan. And then I also included in my infographic the staging and prognosis in general with the breast carcinoma. This is the American Joint Committee on Cancer 8th edition anatomic stage. Actually, this is only used when the information about the grading or there is no information about the HER2 and PR. So those are not available. You can utilize this staging. So stage 0, so ductal carcinoma in situ, there's no invasion yet, no metastasis. Stage 1, there is an invasive carcinoma of less than or equal to 2 centimeters. There is no metastasis or only micrometastasis. As I've read further, mga less, greater than 0.2 millimeters now. So the survival rate is 87%. We have stage 2, composed of A and B. For A, greater than 2 centimeter with 1 to 3 positive lymph nodes. 2B, greater than 2 but less than or equal to 5, and there are 0 to 3 positive lymph nodes. For the stage 3, we have A, B, and C. 3A is invasive carcinoma greater than 5 with positive or negative lymph nodes. Pag sa B, pag greater than 4, greater than or equal to 4 positive lymph nodes, kahit gaano kalaki yung carcinoma, it's considered 3B. For 3C, invasive carcinoma with skin or chest wall involvement, or inflammatory carcinoma with or without lymph node involvement. And as well know, stage 4, kahit anong size, may lymph node man o wala, pero may metastasis, it is already considered stage 4. So my references are Robinson-Cotran, and for the pictures, I got it from pathology.outline.com.
From up above. So liposarcoma is a tumor of the lipoblast and is a rare mesenchymal neoplasm that involves the deep soft tissues. It may include the esophagus, the retroperitoneum, and the popliteal fossa. The relative frequency of liposarcoma at various body sites is dependent on the tumor subtype. And as shown there, it is one of the most common sarcomas in adulthood. So for the epidemiology, the average diagnosis is 50 years of age, but according to Robinson-Cotran, it occurs mainly in their 50s and 60s. Although case reports of childhood onset have been noted, there is no significant association with race or gender, and also there is a slight male predominance that has been reported in some studies. So, as you can see, it is most common in the deep soft tissues of the proximal, remember the proximal extremities, and the retroperitoneum. So, if you can see in the figure on the right, it is an example of a leg that is, this is the, let's say, the knee. Oops. This is the knee, the muscle layer, the subcutaneous, and this is where this liposarcoma is usually found. So this is considered the proximal extremity. But it can also be seen in the retroperitoneum. So features would depend on the location of the tumor. So the history and presentation of liposarcoma are based on the location of the tumor. So usually it is in the extremities, followed by retroperitoneum, and least often in the esophagus. So most patients with liposarcoma have no symptoms, but symptoms develop only when the tumor grows large enough to exert a mass effect on the surrounding structures. So these symptoms include pain or tenderness on the site, edema, loss of function of extremity, paresthesias, varicose veins, fatigue, and weight loss. Nausea and vomiting can also happen. And liposarcoma of the retroperitoneum can grow undetected until late stages due to the obscurity of the symptoms. For physical examination, usually we can palpate a non-tender mass depending on the location. The patients who present with retroperitoneal disease may present with diffuse abdominal distension. Okay, so according to Robinson-Cotran, the key gene in amplified region of chromosome 12q is MDM2, which we will recall this encodes a potent inhibitor of p53. Pleomorphic Liposarcomas contain complex karyotypes without reproducible genetic abnormalities. So for the evaluation, different radiology diagnostic modalities such as barium swallow, CT scan, MRI, or esophagogastroduodenoscopy can be used to diagnose liposarcoma. Although none of these techniques is specific, CT scan and MRI can help narrow down the differential diagnosis as both modalities can detect the percentage of a lipomatous component of the tumor. However, a definitive diagnosis can only be achieved by tissue examination or biopsy. So next, we have three types of liposarcoma. So this is histologically divided into three. We have well-differentiated liposarcoma, which contains adipocytes with scattered atypical spindle cells. So this is indolent in nature. Next, we have the myxoid liposarcoma, which contains abundant basophilic extracellular matrix, arborizing capillaries, and primitive cells at various stages of adipocyte differentiation, reminiscent of fetal fat. So, myxoid meaning mucoid or it has mucopolysaccharide matrix. So, we can see a mucopolysaccharide matrix plus adipocytes of various differentiation. So this is intermediate in malignant behavior. Last but not the least, we have the pleomorphic liposarcoma, which consists of sheets of anaplastic cells, bizarre nuclei, and variable amounts of immature adipocytes, or what we call lipoblasts. So again, in pleomorphic liposarcoma, we have sheets of anaplastic cells plus lipoblasts. So these lipoblasts are actually immature variants of adipocytes. They are visible as large-sized vacuoles, which causes indentation of nucleus or scalloping of the nucleus, as you can see here. So this one, there is an indentation of the nucleus. So if you compare it with a mature adipocyte, they are pushed to the margins. But here, in immature adipocytes, it remains in the center, but it is indented. So na-indent. Okay, so pleomorphic liposarcoma is the one that is aggressive and frequently metastasizes. So, according to Robinson-Cotran, all types of liposarcoma recur locally and often repeatedly unless adequately excised. So, meaning surgical excision is the mainstay treatment.
So, sacrococcygeal mature teratoma, by definition, teratomas include components derived from all three embryonic layers, including the ectoderm, the endoderm, and the mesoderm, wherein these tissues are foreign to the location in which they are found. So, it is a most common germ cell tumor during childhood, with 40% or more cases. 10%, wherein 10% is associated with congenital anomalies, having a female-to-male ratio of 4:1 and an incidence rate of about 1 in every 35,000 to 40,000 live births. So for the clinical manifestation, the symptoms that occur with sacrococcygeal teratomas vary widely depending upon the size and specific location of the tumor. So small tumors often do not cause any symptoms or appears to be asymptomatic and can usually be removed surgically after birth without difficulty. However, larger sacrococcygeal tumors can cause a variety of complications before and after birth. It can grow rapidly in the fetus and require a very high blood flow, resulting in fetal heart failure, a condition known as hydrops. So for the pathophysiology, there are several theories about the origin of these tumors. So one of the best evidence suggests that most of the cases are due to abnormal differentiation of fetal germ cells. And then one study, according to Osteosarcoma et al., they categorized mature teratoma having a chromosomal abnormality with an extra X, 7, 12, and 15 chromosomes. So there is no causative agent that are known and no chromosomal structural anomalies. So this This condition can also be diagnosed antenatally through ultrasound, wherein it appears to have a baby or a fetus that is large for the age. The fetus may also appear to be premature and has fetal hydros. So for the management of this condition, according to Schwartz, there is a need for complete resection of the tumor. So the rectum and the genital structures are often distorted by the tumor, but usually can be preserved in the course of resection. And then we also have to take note of the perioperative complications such as hypothermia and hemorrhage, which can occur with massive tumors and may prove lethal. So I have also here the classifications of SCT, wherein it is categorized according to the classification developed by American Academy of Pediatrics Surgical Section AAPSS, wherein type 1 is described to have a primarily external or has a minimal presacral component. For type 2, there is predominantly external but has a significant intrapelvic component. For type 3, predominantly intrapelvic with abdominal extension with a small external component, and for type 4, it is entirely within the pelvis and the abdomen. So for the prognosis, the prognostic implications of a teratoma diagnosis has been primarily based on three factors. One would be the anatomic location of the tumor, the patient demographics, and the presence of coincidence malignancy, or like for example, having immature histological elements. But for this condition, the mature teratoma, the cure rate, according to Schwartz, is excellent if the tumor is excised completely, and for the recurrence, it can be salvageable with subsequent platinum-based chemotherapy. So these are my references, Doc. Thank you.
Thank you, Dr. Villablanca. So another excellent poster presentation, no? So what caught my attention is the lowest part picture. I think this is from Robbins, no?
Yes, Doc.
Remember
It's from Robbins po.
no, remember ko pa yan. Andyan talaga
Yes,
yun sa
Doc.
Robbins. Ang ganda, no? So parang we describe is the fetus sitting in a rock, no? We call it
Yes.
the sacrococcygeal teratoma. We call it fetus sitting on a rock, no? But what is also attractive in your poster is you mentioned the different types, no? Kasi hindi lang ito ang types, no? Meron palang 1, 2, 3, 4. In your readings, which is the most common of the 4? And maganda ang prognosis. Saan dyan? Anong pinaka most common? Ang pinaka...
Based on what can I yes, Doc.
Anong type?
For what I can remember, Doc, is that for type 1 tumors, they are like they are easily diagnosed, Doc, prenatally, and then they are amenable to fetal resection. However, for babies having type 4 tumors, they can be difficult to diagnose, Doc, and they are not amenable to fetal resection, Doc.
Yeah. Oo, kasi nasa loob na, no?
Yes, Doc.
Oo. Then, ang problem nito is if there are other immature components, no? If there are other immature components. Maganda kung puro lang mature teratoma, no?
Yes.
So
Yes.
again, very good. You discussed your definition. What you mean by teratoma? Then you mentioned also the different types. Can you discuss this microscopic picture? What do you mean by this picture?
This one, Doc, this histological picture, I got this from the internet po. It was a case of a male neonate having mature sacrococcygeal teratoma, wherein it is said, Doc, that it shows that most of the tumor consists of mature epithelial tissue, as shown in the arrow. And then there is also the presence of mesenchymal tissue on the arrowhead, and then the mature neural tissue on the asterisk.
Okay, so that's constitute a teratoma, no?
Yes,
So
Doc.
very good. So I think I don't have any questions. Everything is there. Thank you, Dr. Villablanca.
Thank you so much, Doc.
Next, I guess we have the last presenter but not the least. The future OB-GYN daw siya, no? Si Dr. Zalavarria, because she will be discussing Fibrothecoma, her favorite. Am I right, Dr. Zalavarria?
Fibrothecoma. So here is my whole infographic. Okay, so let's start. Fibrothecoma. So fibrothecoma, they represent a group of benign tumors arising in the ovarian stroma, and they exhibit a morphological spectrum consisting of fibroblasts producing collagen, hence the term fibroma, and a clump of spindle cells with liquid droplets, hence the term thecoma. So therefore, fibrothecoma are tumors that contains a mixture of these cells. So these tumors occur generally in older menopausal patients. However, some authors report two peaks of frequency. The first peak of onset is after menopause, and the second peak of onset is between 20 and 40 years old. It constitutes about 4% of all ovarian tumors, and the tumor, according to study, it is usually unilateral in 90% of cases with an average diameter of 6 centimeters. So what does it look like? So macroscopically, fibrothecomas are very similar to your fibroma. Grossly, fibrothecomas are usually ovoid, round, or lobulated encapsulated hard gray-white masses covered by intact ovarian serosa. Edema and cystic degeneration are relatively common. Studies reported that fibrothecoma of more than 10 centimeters, so this is already large for a fibrothecoma, tend to be associated with myxoid change or degeneration. Also, discrepancy between arterial and venous and lymphatic drainage could lead to stromal edema. For its histologic examination, microscopically, fibrothecomas are composed of intermingling bundles or anastomosing trabeculae of ovoid fecal cells with round and pale nuclei containing lipid droplets and fibroblastic fusiform elements. Granulosa cells separated by collagen bundles have also been observed. Next slide. So did you know that fibrothecoma and urticomas, which is very rare, may be hormonally active compared to your fibromas, which are hormonally inactive. So therefore, fibrothecomas exhibit estrogenic activity. So patients with fibrothecoma, they may experience estrogenic symptoms such as endometrial hyperplasia, menorrhagia, and such. So for the symptoms, the clinical presentation of ovarian fibrothecoma is usually non-specific. Most patients come to attention as a pelvic mass, sometimes accompanied by pain and menorrhagia. And also, it has two decidedly curious associations, namely Meigs syndrome and basal cell nevus syndrome. So for the Meigs syndrome, it is a triad of ovarian tumor, usually on the right side, plus ascites and hydrothorax. For basal cell nevus syndrome, so bilateral ovarian fibrosarcoma plus multiple basal cell carcinoma of the skin and odontogenic keratocysts. So as I mentioned earlier, fibrothecoma and urticomas, they may show symptoms of menstrual irregularities, amenorrhea, endometrial hyperplasia, and endometrial carcinoma. So what are the diagnostics needed for fibrothecoma? So still, the definitive diagnosis of fibrothecoma is histopathology. However, imaging studies could be done, such as CT scan and MRI. So for the CT scan, it may appear as a homogeneous solid tumor, varying degrees of enhancement. So in 79% of cases, it is a solid mass with delayed accumulation of contrast nucleum. However, in 21% of cases, tumor is partly or mainly cystic. On MRI, it is predominantly low signal intensity on weighted images. Also, scattered high signal areas may be present, representing areas of cystic degeneration with or without edema. So for the diagnosis and treatment, early diagnosis and surgical resection is the treatment of choice for ovarian fibrothecomas. So the accurate preoperative diagnosis of ovarian fibrothecomas with cystic degeneration could have prevented the extensive surgical interventions such as bilateral salpingo-oophorectomy with hysterectomy. Tumorectomy is also indicated in young patients, while radical surgery in terms of bilateral salpingo-oophorectomy is indicated for perimenopausal and menopausal patients and is associated with a good prognosis.